This last DRP talks about adherence or noncompliance. It has the same thoughts for C7, C3.5, C1.5, and C1.7 of PCNE version 8. Adherence or noncompliance is affected if the patient does not understand the instructions, the patient cannot afford the drug product, the patient prefers not to take the medication, the patient forgets to take the medication, and the drug product is not available for the patient. Also, if the patient cannot swallow or self-administer the drug product appropriately. For example, if the patient is not able to remember to instill her timolol eye drops twice daily for her glaucoma. When a practitioner decides that a patient's drug therapy problem is an adherence problem, he or she must be certain that the patient's medication regimen has been judged to be therapeutically indicated, effective, and safe. Recall that the term compliance is used to mean compliance with the dosage regimen, not with the orders of the paternalistic or authoritarian figure. When clinical pharmacists conclude that a patient is being non-adherent, it means the following. Non-adherence is defined as the patient's inability or unwillingness to take a drug that the doctor has clinically judged to be appropriately indicated, adequately efficacious, and able to produce the desired outcomes without any serious harmful effects. There is a reason for all non-adherence, and it is the practitioner's responsibility to discover that reason. The cause or reason for non-compliance determines the intervention and care that are necessary to alter or improve the patient outcome. Keep in mind, if the patient stopped taking a drug because it was not being effective, it is an effectiveness problem, not a compliance problem. Similarly, if your patient stopped her medication because it was making her too dizzy to stand up, it is likely a safety problem and not a compliance problem. Less than 15% of all drugs therapy problems are compliance problems. In order to successfully follow any set of instructions, patients must first understand the instruction. Clinical pharmacists and other practitioners often use language and terminology that is unclear to or not understood by the patient. Sometimes, patients have different definition of terms, and these differences can result in misunderstandings, confusions, and non-compliance. Patients can have very different interpretations of common physiology used in prescription directions, such as 2 times a day. What message are you trying to send to your patient with instructions such as take this medicine twice a day? Most often, the intended message is 2 doses, taken about 12 hours apart. However, without being explicit about these instructions, patients may just interpret 2 times a day quite differently. Consider what time frame is intended when common activities such as telephoning a friend or checking your email twice a day are described. So be specific in your instruction to your patients. Each patient decides whether to be concerned about signs, symptoms, or the discomfort present, and decides to agree or not to agree with the diagnosis that is presented. Furthermore, patients decide whether they believe that the proposed therapy is likely to achieve their desired outcome. Patients decide how they will comply with medications. Patients tend not to take medications that they do not understand. They usually do not take drug therapies that they believe will not benefit them. Patients also do not take drugs if they have safety concerns about the product. Similarly, people do not begin taking a medication without their own preconceived ideas, nor do they enter a healthcare system without such preferences. They have their own healthcare beliefs, ideas about medications, and most importantly, They have ideas about what they want and what they want it, and when they want it. Patients weigh the advantages and disadvantages of drug therapy, the risks and benefits, and the possible discomfort of changing their own behavior against the likelihood of a positive outcome. As with many As with any person who is asked or expected to follow a set of directions, the patient must determine for herself whether doing what the practitioner has recommended is really going to be in his or her best interest. If patients believe that it will be, then they are likely to do their best to comply with the instruction. On the other hand, patient package inserts and coaching by clinicians will be of little value if patients do not perceive that a condition can cause harm or discomfort, or if they do not believe the recommended therapy will reduce the threat or discomfort caused by the ailment. When patients choose not to take a medication as intended, they have what they consider to be a good reason for not accepting advice and complying with their prescription instructions. Practitioners must internalize the fact that patients' perceptions and healthcare belief systems discovered during the assessment process are major driving forces that ultimately influence the decision to seek care or not, to follow instructions and advice or not. Patient behavior associated with taking medications has a significant impact on pharmacotherapy outcomes. The last category, which is non-adherence, describe patients' actions when they do not or cannot adhere to the instructions. The rate of non-adherence among patients receiving comprehensive medication management services care is very low. This category of drug therapy problem is resolved through interventions such as explaining how the medication works or the pharmacology that was taught to us, and how the patient will know if it is being effective, or we should lay out the goals of therapy to the patients and making the instructions clearly understandable to the patients. Providing the patient with a daily medication diary, medication administration reminders, calendars, pill boxes, and access to free medication programs or price reduction programs offered by some manufacturers or the government also. Here are the lists of some medications most frequently involved in problems of non-adherence that we have to take note. First, simvastatin, then metformin, atorvastatin, insulin, fluticasone, lisinopril, albuterol, exenatide, levothyroxine, and rosuvastatin. Here are medications also with instructions that patients often did not understand: albuterol, fluticasone, metformin, insulin, mycophenolate, simvastatin, omeprazole, levothyroxine, aspirin, and lisinopril. This list also is the list of medication patients often preferred not to take: metformin, simvastatin, fluticasone, lisinopril, insulin, atorvastatin, furosemide, hydrochlorothiazide, gabapentin, and exenatide. This slide is about the medications patients often could not afford to purchase: simvastatin, atorvastatin, lisinopril, rosuvastatin, insulin, esomeprazole, fenofibrate, losartan, fluticasone, ezetimibe, and simvastatin. This list is about medications patients often forget to take as instructed. Many patients receiving pharmaceutical care have to manage multiple drug therapies. More than 30% of patients require 10 or more different drug regimens, several of which require multiple doses each day. That is why patients often forget to take them as instructed. Simplifying a patient's drug regimen can have a dramatic impact on the patient's ability to follow all the instructions given to them properly. Simplifying the instructions for the following drugs can be very beneficial. Drugs such as metformin, simvastatin, fluticasone and salmeterol, exenatide, mycophenolate, lisinopril, prednisone, insulin, tacrolimus, and metoprolol. This list talks about medications involved in drug interactions requiring interventions that make our patients fail that make the patient's failure to comply. The drugs are clopidogrel, omeprazole, aspirin, calcium carbonate, levothyroxine, warfarin, ibuprofen, pantoprazole, simvastatin, and tramadol. Now, we have reached the end of our lecture. We have discussed 7 DRPs that are listed from Cipollet et al. And from PCNE version 8. For the third part of the lesson, we will talk about how to state DRPs and how to communicate it to our doctors in order for intervention and resolution to be applied. Thank you very much for listening.